Okay, great. Thank you so much. So thanks so much, everyone, again, for being here today to discuss such an important issue. This event is being hosted as a collaboration between David's Hope and Mayo Clinic. Our goal for this event is to learn how to reduce incarceration rates for individuals with mental illness by focusing on diversion from the criminal justice system and improving communication between healthcare professionals and law enforcement. I feel so honored to have been a part of this, as understanding these issues is necessary to ensure justice and care for those with mental illness. We have some phenomenal speakers here today from many areas of expertise, including a Justice of the Peace, Senior Special Project Consultant at the Supreme Court of Arizona, a Crisis Intervention Team Coordinator and Detective, a psychiatrist, and someone with real life experiences in the criminal justice system, who's now the Senior Director of Community Programs at Hope Incorporated. So for the event layout, we will begin with some opening remarks from Chief Justice Brutinel from the Arizona Supreme Court. And then Audrey, an executive board member from David's Hope, will launch a poll asking a few questions about your experiences in this space as event attendees. And then after the poll, our wonderful co-moderators, Teresa Fuller and Dr. Karen Burstein, will take over and ask the panelists to introduce themselves. We're going to wrap up the panel at about 1:10 p.m. for some final words from Audrey at David's Hope. So as an introduction to our moderators really quick, Teresa Fuller is currently the Manager of Victim Services and Adult Diversion for the Pinal County Attorney's Office, and Dr. Karen Burstein is a Senior Scientist at Learning Well Consultants. With Dr. Burstein as a Principal Investigator, they are currently working on a Bureau of Justice Assistance funded digital transformation of community supervision in Pinal County. Thank you both for moderating today. As the event proceeds, please feel free to put any questions you have in the chat. The moderators will be monitoring the questions coming in and include those relevant to the discussion. Due to time constraints, we may not get to every question. Thank you everyone again for coming today and for caring about this issue. I will pass it off to Chief Justice Robert Brutinel for the opening remarks. He is currently a Chief Justice for the Arizona Supreme Court and has served as a co-chair on the National Judicial Task Force to examine state courts' response to mental illness. We feel honored to have him. Thank you for being here, Chief Justice Brutinel, and thank you everyone again for coming in the audience. Whenever you're ready, take over.
Thank you, Ms. Bennett. And thank you for the opportunity to talk about the challenge of improving the justice system's response to individuals with mental health challenges. Welcome to all of you, including the second-year medical students. This program is about the important goal of reducing the incarceration of individuals with mental illness in Arizona. As any judge, police officer, probation officer, or child welfare case manager can tell you, justice system contact with the mentally ill is quite common. Research reflects that more than 25% of incarcerated people have had a recent history of mental illness and require ongoing mental health services. As many as 70% of children in the juvenile justice system have at least one mental health condition, and 20% experience severe mental illness. When I was doing dependency cases, I used to be a trial judge. That is, child welfare cases, we used to estimate that better than 90%, actually closer to 95%, the parents either suffered from a mental illness or substance abusers, or both. We know that people with a mental illness will have disproportionate contact with the criminal justice system, from law enforcement interactions to arrest, to pretrial detention, conviction, incarceration, and prison. Sadly, we recognize that the justice system is a primary gateway for people to access our mental health systems. And like Judge Steve Lightfoot of Miami-Dade, Florida, who I see is prominently featured on the David's Hope website, and who had the epiphany that he was running the largest mental health treatment facility in the state of Florida, that is 2 floors of the Miami-Dade County Jail, we understand that jails and emergency rooms are not the appropriate place to provide treatment for the mentally ill. Simply locking up mentally ill people does nothing to treat their illness or to address the reasons that they came in contact with the justice system. Similarly, using the police and the jails as a substitute for evaluation and treatment uses a tremendous amount of resources that are badly needed elsewhere, from police officers waiting for hours in emergency rooms to the lost families, jobs, and homes of people who are needlessly locked up, again with little benefit to the community and frequently actual harm to the individual involved. I'm proud to say that Arizona, the Arizona justice system, which includes a number of the members of the David's Hope Coalition, are national leaders in stepping up to improve courts' responses to mental illness. There's a lot of great work being done in this area in Arizona, but of course we have a long way to go. The Arizona Supreme Court created its Committee on Mental Health in the Justice System in 2018. In 2019, the court held a statewide summit to bring multi-agency and multidisciplinary teams together to start the process of implementing what is called the sequential intercept model in each county. Since then, Arizona's judicial branch has been working to develop protocols and resources across disciplines and to focus on the sequential intercept model. That is to identify opportunities to intervene as early as possible at each step in the criminal justice process, from the first contact with a police officer to return to the community after completing a prison sentence. To train people throughout the system to recognize mental illness and to know where to refer people who have mental illnesses. The idea is to prevent individuals with mental illness from entering the system, or if they get into the system, to get them out of the system just as quickly as we can. These issues are now receiving a national focus. The Conference of Chief Justices and the Conference of State Court Administrators created a National Judicial Task Force to examine states' courts' responses to mental illness. Among other things, the task force just approved a white paper on designing a better process for determining competency to stand trial and competency restoration. But for the first time, we're also actively looking at how to improve the court's response to mental illness outside of criminal cases. For instance, the Upstream project is designed to apply the sequential intercept model to child welfare cases. Again, if you've ever dealt with child welfare cases, you know there's mental illness involved. Identifying people and getting them to appropriate treatment can't help but make things better for children and families in that system. We're working on a similar mapping process for the juvenile delinquency system. That is the system in which children are charged and dealt with for having committed criminal acts. We're working on a model statute along with the Equitas project to fix the civil commitment process to make it easier to get people who desperately need help into the civil commitment process while protecting their civil rights, and also to emphasize outpatient treatment and assisted outpatient treatment instead of the locked inpatient model we commonly use now for involuntary patients. And we're working on an education process to roll these things out to the various states of the union and to convince all of the states of the United States that these are issues which we all need to start working on right now. Arizona will continue work on implementing the sequential intercept model throughout Arizona's courts and in partnership with other system partners to train everyone who comes into contact with the public to identify and respond to mental illness issues. We are working to identify the data we need to track our performance and to identify disproportionate minority contact with our courts. We have never asked those questions. Do we treat people differently based on their skin color, for instance, as to whether they get mental health services and are they committed at a higher rate? But we're asking those questions now, and we're trying to identify that data. And we will expand those efforts to cases other than criminal cases, so that, for instance, high conflict divorce cases, juvenile cases, the areas we're going to take a look at to see if we can identify mental illness and again get people to the treatment that they need. With your help, Arizona courts will continue to make progress and maintain its commitment to leading in research and responses for improved court services for individuals with mental illness. I appreciate the opportunity to speak to you today, and I particularly appreciate your interest in the many issues affecting mental illness and its intersection with our justice system. We've got an outstanding panel coming up, including my colleagues Judge Velasquez and Don Jacobson, and I'm sure it will be a lively discussion. And with that, I'll turn it over to Audrey Dorfman to start with the panel discussion. Thank you.
Thank you, Chief Justice Brutinel, for your leadership, not only in Arizona, but across the nation in advancing the Stepping Up initiative. For a long time, you've been a champion of vulnerable populations, and this coalition and David's Hope are grateful. So thanks for being here today.
Good to see you.
Okay, everybody, it's poll time. So, and the reason we do this poll is so that it helps us prepare future programming for the coalition. So the first question is, my relationship to a person living with a mental illness or an addiction is as a peer or family member, as a professional, as both a peer and family member and a professional. So if you can. Great. I'll give you a few more seconds. I see numbers popping up. So question number one, as a peer and family member, 24%, as a professional, 31, as both a peer, family, and professional, 44. Question number two, how often have you utilized resources from National Stepping Up Initiative, Strategy Lab? Looks like 74% never, 22% seldom, and 3% frequently. And our final question, do your county leaders publicly support the Stepping Up Initiative, reducing the number of people with mental illness and addiction in jail? 53%, I never heard my county leaders speak about it. 20% said, I have heard about Stepping Up Initiative, and 25%, I know the county I live in has leaders who support the initiative. So I'm going to end our poll, and I thank you very much. And now I'm going to turn it over so that our moderators can begin the program.
Teresa, did you unmute?
My apologies, everyone. I thought I did unmute. Good afternoon, everyone. As Kelsey said, I am Teresa Fuller, and I am the manager over Victim Services and Adult Diversion for the Pinal County Attorney's Office. And my co-moderator is Dr. Karen Bernstein. I would like to take a moment to welcome all of our panel members and our audience. In the second part of today's presentation, we are pleased to have the opportunity to pose a series of thoughtful questions informed by our audience and by your interests. Our format today will pose questions specific to panel members, after which other panel members will be asked to share their thoughts. During the panel discussion, the audience is encouraged to post questions to the chat. If time permits, we will pose these questions to the panel as well. As we introduce each panel member, would you please share your background as it relates to today's topic, including work in the mental health system, integrated healthcare, the criminal justice system, lived experience, Stepping Up initiatives, or other community service. We'll start with the Honorable Judge Emilio Velasquez, who has served as the Santa Cruz County Justice of the Peace since 2015. During his tenure, he has introduced numerous innovative programs focused on mental health and substance use disorder, including the Adult Drug Court Program and Mental Health Program known as the Behavioral Empowerment Court. And in conjunction with community agencies, Judge Velasquez led the formation of the Behavioral Mental Health Substance Abuse Community Court Coalition in Santa Cruz County. Judge Velasquez, do you have anything to add? Did he make it on? I know we were waiting on him.
Here, yes.
Muted.
In that case, I'll move on.
I'm sorry, I just unmuted myself.
Oh, good.
Okay.
Sorry about that. Yeah, the only thing I just want to add is that aside from that is that I have extensive background in terms of mental health and drug addictions, having been a big part of that during the it was a revolutionary time during the late 80s and 90s when the limelight started getting onto mental health and drug addictions. So there's an extensive background on there that I have been able to utilize now in the court system.
Thank you.
Welcome, Judge, and thank you for being here. Next, we have Mr. Richard Sandoval, who is the Senior Director of Community Programs at Hope Incorporated, where he's worked for 9 years. In addition, he has lived experience with mental health and substance use recovery. He is a Marine Corps combat veteran who served in Operations Iraqi Freedom 1 and 2. Thank you for your service, Mr. Sandoval. Do you have anything to add?
Yeah, good morning, everybody. Thank you for this wonderful opportunity. It's great to see some familiar faces. Martine, we miss you, man. But just overall, just to talk about a little bit about what we're doing here in Tucson with working with Pima County Jail and the prisons. You know, we have great relationships with the health plans like Arizona Complete Health and Banner on seeking out and identifying individuals that really need that support and help, identifying social determinants of health. But most importantly, just in the past year and a half, partnering up with AZCH and working with the individuals that have wonderful programming in the Wilmot prison, like the Men in Recovery community program. Their name has changed. The RSS program that they have going on, and how we're just really expanding our criminal justice services across the board in all the areas that Hope Incorporated is there. You know, we're really starting to see an increase of how much Arizona is still underserved when it comes to the support that they're needing in the hospitals and in the jails and the prison system, and the effectiveness of how that peer support could be there, of meeting the individuals of where they're at, meeting them inside while they're there, so that by the time they're getting into the community, they have those supports. And, you know, that's that effectiveness of guys like myself who have that lived experience and can help individuals who need to be able to navigate the system and move forward in their recovery. So I'm really, really excited that this is coming up, and thank you for allowing me to be on this panel. Thank you.
Thank you.
Thank you. That's part of it. Next, we have Dr. Marjorie Balfour, who is the Chief of Quality and Clinical Innovation at Connections Health Solutions and an Associate Professor of Psychiatry at the University of Arizona College of Medicine. Dr. Balfour was named Doctor of the Year by the National Council for Behavioral Health for her leadership at the Crisis Response Center in Tucson, Arizona, and CIT International Practitioner of the Year for her work to help law enforcement better serve people with mental health and substance use needs. Dr. Balfour, welcome. Did you have anything you wanted to add?
Yeah, and thanks so much for having me. And so like it said in the bio, we operate the Crisis Response Center down in Tucson. For those of you up in Maricopa region, we also operate the Urgent Psychiatric Center in Phoenix. And these are really meant to be places where anyone can walk in to get care. The police can drop people off to prevent them from going to jail in the first place and ending up in the courts. And I'm sure we'll talk about that later in the panel discussion. Across nationwide, this is a really exciting time because there's lots of interest in crisis for various reasons, which we can talk about later in the panel, but there's legislation coming out, there's funding coming out, and people are looking at Arizona as a model. I mean, everyone likes to complain about the system that they're in, including me, right? But compared to other states, Arizona is actually really far ahead in terms of mental health crisis care. And so I do a lot of work nationally trying to help inform national standards that are finally coming out for crisis as well.
Thank you.
Thank you, Dr. Balfour. Next, we have Detective Amanda Stantz, who recently retired from the Mesa Police Department, where she most recently served as the department's Crisis Intervention Team Program Coordinator. In 2015, Detective Stantz became the first full-time CIT Program Coordinator for the Mesa Police Department, and she was involved in the creation of the Crisis Response Team and the current co-responder model. While working on a doctorate in behavioral health, Detective Stantz currently is a reserve officer with Mesa PD. Detective Stantz, welcome. Did you have anything you wanted to add?
Sure, I don't want to answer any questions we might answer later in the panel, but I'm very grateful to be here. I kind of see my position as the boots on the ground person, as you know, the majority of my jobs include working with the line level first responders, which I think is really important to bring into this conversation. And I've really been interested in stepping up for years. I've been involved in mental health training since 2004. So my career has mostly been focused on that. But what I see now is a swing away from training into more programs that stepping up is going to be able to help us push forward to kind of change what the focus of how we're going to improve diversions out of the criminal justice system. So thanks for having me.
Thank you.
And last but certainly not least, we have Mr. Donald Jacobson, who has served as the court administrator, consultant, and trainer in both general jurisdiction and limited jurisdiction courts throughout Arizona for the past 28 years. And he currently serves as the Senior Special Project Consultant for the Arizona Supreme Court, Administrative Office of the Court. He's recognized for his expertise. Mr. Jacobson is the recipient of numerous awards, including the Presiding Judges Award in 2010, the NACM ICM Fellow Star Award in 2010, the Administrative of Justice Award in 2011, and the Summit Award for Criminal Justice in 2014. Welcome, Mr. Jacobson. Did you have anything you'd like to add?
Yeah, just kind of a little bit of background to add to what Justice Brutinel was saying earlier. One of the interesting things about our current emphasis on those who have a mental illness in the justice system actually began as we started to look at the disproportionate impact of finances. We had a task force called the Fair Justice Task Force that began to look at how those who are challenged financially have had a disproportionate impact in the justice system, the setting of bail, financial fines and obligations in the justice system. And as we began to look at that, we discovered that there's a whole other group within that, those that have a mental illness. And that actually began our march, if you will, towards working with these individuals in a different way. And what Justice Brutinel, I think, was talking about is that we're having to kind of retool and rework our perspective of what is a successful conclusion of a case. And I'll jump into that a little bit more later. But it came out of that process and is continuing as we begin to see how these individuals are disproportionately impacted by the system that they end up becoming part of.
Thank you, Mr. Jacobson. So we're going to jump in with our questions. The first one I'm going to pose to Judge Velasquez. Given your many innovative community practices, what types of effective coordination activities or approaches have you observed between professionals working in criminal justice, substance use treatment, mental health, and other aspects of healthcare? And what is one recommendation for improvement that you would like to see?
Thank you, Ms. Fuller. So one of the things is that when we initiated this whole sequential intercept model that was led by Mr. Jacobson, one of the things that we did was, we're in a small community in Santa Cruz County. So one of the things that we had to do was we had to get very innovative and creative in terms of how we were going to be approaching the community and making sure that everybody would be buying into the sequential intercept model, and that we would be able to work with uniting all the agencies in working together, from mental health agencies to the law enforcement agencies, et cetera. One of the things that we did was, we were able to hold a meeting and where we were able to bring everyone together to be able to talk about what our vision was in terms of getting treatment for these individuals that were coming into the jail. And it's not a place for these individuals with mental health and drug addictions to be placed in jail and kept there. I think one of the things that our goal was to make sure that we were getting treatment for these individuals as they were getting arrested. So for us, it was making sure that all the agencies were working together in the vision that we all had. And one of the things that we also wanted to make sure was that the attorneys, defense attorneys, and that the prosecutors were all also in belief of what our goal was going to be. So in communicating and in meeting with these people on a consistent basis, I think has brought some unity in terms of our community in trying to get things achieved and trying to get this model in place, but also to be able to to be able to get creative in our community and the challenges that we faced. So one of the things is that many years ago, I was told that I wouldn't be able to be very successful with a specialty court here in Santa Cruz County because of the resources. We don't have the resources of the big cities. You know, we were also told that I was also told that it would be really hard to get someone like a jail liaison that would be able to work with the jail and would be a bridge to the courts in trying to achieve our goals. And so what I did is I got very creative in working with these individuals, making sure that they were communicating. I also made sure that I didn't have the funding. So one of the things I did was I went ahead and got a $500,000 grant, $1 million grant that I was able to implement an adult drug court program and mental health court program. And I actually got creative and got an individual actually from Hope, who is now with us, Martin Felix, and he's been the Pied Piper of our community in getting these people treatment. So I was able to hire him as a jail liaison. So at this time, everything that is happening is because of the communication and the support that we're getting from the community. But it was very delicate for the you know, as a judicial officer, as a judge, it's really something I have to be careful, because as a judge, you can be there to support them and to communicate with them, but you also have to make sure that these people don't view you as a broker, that you're there to refer to agencies and to, you know, put them in competition. So so at this time, I think with the communication that we've had with each other and the vision that we have shared, we've been able to successfully get to where we're at.
If I may add a comment to what Judge Velasquez said there, and Emilio, I'm so glad you're here with us today, because you pointed out just an issue that is really crucial in terms of the whole judicial response to this issue. And that is, we have to create individual county, sometimes even smaller community-based responses to the issues associated with this, because it can't be from a statewide, it can't be just the Supreme Court saying this is how everybody's going to do it, because we have such diversity within our communities, within our counties, the demographics, the populations, all those things are extremely different. And I think what Emilio's really exemplifying here is that he's taken an approach that works in his county. And that's what we're trying to duplicate as we move through the other counties and see those other entities come on board. So I'm just so glad you had a chance to at least briefly talk about all that's going on down there.
Thank you, Mr. Jacobson.
We have a question from the audience, and they would like clarification on what does PACT stand for? P-A-C-T.
P-A-C-T?
Yeah, hi. Yeah, this is Richard. I was just responding to Kelsey's question. And so our peer aftercare team in Pima County is our peer aftercare team. As we're talking about individuals, especially going to the question that the panel's even going to ask, it's, you know, Hope's mission and vision and model that we are doing right now across the board in Arizona is learning how to meet the individuals where they're at. So it's meeting them in the prison, it's meeting them in the jail, it's meeting them in the hospitals, and it's starting to build that relationship. It's starting to build that rapport. It's starting to build that that trust that they don't have any type of relationship within the community. You know, they could be connected with a provider, but it doesn't mean they trust them. It doesn't mean they trust them to really help them to get to where they need to get into the community and into their recovery. So as a secondary crisis response team, we are able to do that. We provide a lot of more intensive services where we're meeting the individuals. You know, one of our biggest hospitals that we go into on a daily basis and receive a lot of referrals from is from the CRC. And we're able to go in there every day and talk to individuals about peer support in the community, and that we are an extra support, and that we work with the individuals and their providers to better support them in the community. And the great thing about us is that we could provide more of that intensive peer support on a consistent basis. that a lot of places, that a lot of other agencies don't have 5 or 6 hours a day to spend with one individual as they just get out of the hospital. We do, because we have that quality of time, and we understand that time that that individual probably needs to get from point A to point B, start developing those skills. But then not only that, really build that trust with them that we are going to be there for them and help guide them through this process and navigating resources. And that even includes, you know, navigating the legal justice system, getting them connected to food stamps, you know, food boxes, anything that they're really needing. You know, we're identifying those social determinants of health, but then also getting them reconnected with their health home, setting up art meetings, medication management, you know, everything we can do to help develop skills so that they're not going back into the hospital or some form of system.
Thank you.
You're welcome.
Teresa, I'll turn it back to you.
Mr. Sandoval, you talked a lot about the importance of rapport building with community service providers and linking individuals to the services they need based on their individualized need. I'm curious, from your perspective and that of the individuals you serve and their families, what do you think is the biggest gap in services for individuals with mental illness?
The biggest thing I've seen, and it's the same thing with anybody who's getting out of the prison, the jail, hospitals, is just proper support. When you have nobody talking to these individuals and they're just getting released, they're not really being guided on where to go to. They're told about their next doctor appointment, but who's actually there to help walk them through this process? I'm not saying you got to hold their hand, because in recovery, it's about having that individual meet you halfway. But what if that individual isn't even from Tucson or Pima County and they're just getting released from the hospital and they have no idea where to go? They're so stressed out, they're so embarrassed, and they have no idea what to do. They're homeless and they don't even know where to go in the community to be homeless, to get food, anything. And we see it all the time. So when you have another peer there that could help direct you and navigate those resources for you and be more of a support system, and you're building that trust with them, then they're more likely to follow up with you instead of you always having to follow up with them, and get them actively involved and engaged in services. So it's having that support. It's knowing the resources, and it's equipping every individual to help out with finding a way to get some form of transportation, helping out to find some way of how employment would be going, getting just some food, getting, you know, being able to direct individuals on how they could get connected this way or another. You know, there's amazing programs where I see, especially in the prison right now, where we're doing an amazing collaboration with 2 of the units, and these guys are getting out. They have housing, they have everything set up for them, but it's mainly because they engage in a program, which is great. But what about a lot of the other individuals who didn't have a chance to get into that programming, and they're just dropped off at the Greyhound station with nothing else? All they have is a box with their clothes and whatever letters. They have nothing else that's given to them. So it's connecting them with halfway houses or employment, or even how to even get to parole. It's very, very difficult to have that. And you know, you feel it even more, especially after you're getting out of some of the psych hospitals. Most likely, if you don't have anybody to contact them within 24 hours, or they haven't met with somebody who's there to really understand, and that's that effectiveness of peer support, they're more likely to go back into the hospital, and we've seen it. And there is a high number of those readmits because there isn't that proper support. And so that's what it is. It's equipping everybody, providing that peer support, and getting people connected into those services and those resources that are out there. If more of the workers that were more equipped and educated on the programs that are out there, which we're getting there, then they could start to refer to more of these amazing programs that are all out there, so that you could get these individuals to not readmit into the hospitals, the prison system, and the jail system. So yeah, and Judge, thank you for sharing. You guys have such an amazing guy working for you. I don't like you guys for taking Martin, but you know, he's gonna do amazing things in that community, Judge. So I'm happy for him. Martin, I'm looking right at you, but I'm happy for you guys so much. Martin's gonna do some amazing things out there.
And I really appreciate you saying that, because, you know, I think it's really critical of what you just said right now in terms of peer support. One of the things is, you know, we deal with a population that has been ousted by society, if you will. And I think one of the things that now we're finding is that the limelight has come to mental health and to drug addiction. And one of the things we have to start with is we have to start off with making sure that we have the compassion to treat these individuals, and at whatever level it is, whether it's in the courts, whether it's in the agency, whether it's by law enforcement. The bottom line is that these people are human beings. And I think one of the things we have to make sure is that we don't stigmatize them, and that we have compassion for what they are going through, because I'm sure we all know or can relate to someone because of situations that they may be in. And thank you, Mr. Sandoval. I'm very, very honored to have Martin with us, because he's going to make, like I said, he's a Pied Piper in our community. Everybody knows him. And for him to be that bridge between us and the jail is just going to be tremendous.
Thank you, Judge.
Well, thank you, Judge, and thank you, Mr. Sandoval. I have a question. So you would say the biggest service gap you see is knowledge of providers around all of the other services that are out there?
Yeah, and also understanding what they do.
Okay.
It's a big piece, is because if there's someone who needs specific employment or housing or something else, or more consistent follow-up, if you have individuals presenting their programs and workers who are helping to do the discharge planning are more actively involved, then you know exactly the services that they're providing, and you could connect it to those community resources.
Great. How about the other panel members? Do any of you have a different take on what the biggest service gap is today?
I would say with the people that we see in crisis, as we're trying to transition them or look at things that can prevent their crisis and then transition them somewhere where they're going to be able to do well, is housing. Readily available, low demand housing, that can accept somebody, in a moment's notice. When it's my turn, I'll talk more about what we do at the CRC, but not having a safe and stable place to lay your head at night, it's hard to address all the other stuff if you don't have that taken care of.
Thank you very much. Okay, Teresa, I'll turn it back to you.
Well, on that note, actually, Dr. Balfour, from your experience, what do you see as the chief obstacle to implementing community-based coordination services?
So I think the access to care is probably the most difficult thing across the nation in terms of preventing people from going into the justice system. The mental health system has a reputation, which is kind of well-deserved, of being difficult to access. It's this mysterious thing. Some people say it's easier to get into heaven than to get into a psych facility. Mental health programs have all these different restrictions. You can't be too intoxicated. You can't be too violent. You can't be too this. You can't be too that. You have to have this insurance, but not that insurance. And it's complicated. That's why what Arizona has done is really focused on making it so, I don't want to get too much into like the policy wonkish stuff, but what they've done with our Medicaid department, which is access, and the way they've combined funding sources from different places, makes it so that people don't have to worry about that as much. And then the other part is that having this culture of, we're going to accept everybody and we're not going to make it this wild goose chase. We call that no wrong door. So we live what we do in our crisis centers in sort of that intercept 0 and 1. So the part of the justice system where you're trying to prevent people from being arrested in the first place. And you've heard lots of, it's really been in the news a lot around getting the police out of the business of being the default first responders. And there's, we've got crisis hotlines here in Arizona that can resolve a lot of crisis on the phone. We have crisis mobile teams that can respond out in the community and resolve those crises out in the fields. Across the state, there's starting to be more of these partnerships where the crisis line and the mobile teams are embedded in 911 to try to divert those in the first place. And all of that is great, but then you need, and the officers are trained in CIT. So, they're trained to recognize signs and symptoms of mental illness and de-escalate people and then divert them to treatment rather than take them to jail. But at the end of the day, they still need somewhere to take somebody, because if the only option is to take them to the emergency room, like the judge mentioned at the very beginning, that's a bad place for someone who has a mental health issue. You don't get good care. I mean, they do their best, but it's just not set up to deliver psychiatric care. You end up getting put on a list to wait for hours to go to a psych hospital somewhere, or the officers have to wait there oftentimes forever when they should be out there, fighting crimes and doing police officer stuff. And so the crisis centers that really need to operate with this no wrong door approach, meaning we want the highly agitated people. We want to make it easy for the police to do the right thing, which is drop them off somewhere where they're going to get treatment, and not have, in order to do that, we have to treat the officers as a customer, just like we treat our patients as a customer. And what we've learned over the years is what police officers like is to get in and out as quick as possible, have their own entrance, so they're not like, going through the awkwardness and stigma of, bringing somebody through in handcuffs to the waiting room, everyone's all staring and gawking at them, getting back on the street in 10 minutes or less, and not being hassled about taking their guns off. I mean, that's pretty simple. So, and never ever turning them away. So that's what our crisis centers do, is have that really quick drop off so they can get back on the street. And then also, you want to get the solution for everyone is not just to go to the hospital. You want to do things in the least restrictive way possible. You want to get people well in the community, in community-based care whenever you can, versus having people involuntarily committed to a hospital against their will. So that's why at our crisis centers we have interdisciplinary team of psychiatrists, nurse practitioners, nurses, lots of peers, social workers, who are really trying to figure out how to get that person the care they need on the outside. And as someone mentioned, because there's some questions going on in the chat, what happens after the crisis? And that's just as important. Just the way that regulations and billing work is that, our crisis observation units are 23 hours and 59 minutes. Well, your crisis doesn't flip off like a light switch in 23 hours and 59 minutes. So you need, what's going to happen after that. So Hope has great programs where they help get people connected. We didn't really have that up in Phoenix, so we started our own transitions clinic that kind of does that. Our regional behavioral health authority has set up like crisis residential for people who need some extra time, to continue to get stable. And the most important thing, though, is that all of these things work together as a system. Like every time you open the news, there's always some story about some cool new program, in some states, some communities opened up. And programs are cool, but they have to all work as a system. So like every piece of it is about getting the person connected to the care they need, and trying to get that crisis resolved in the least restrictive setting and getting people out in the community.
Dr. Belfour, I have a question for you in general, and this might sound like a silly question, but do we have a shortage of competent and trained mental health workers? Correct?
Everywhere does, yes.
Everywhere does. And
yes.
So, I mean, what you're talking about seems sort of intuitive that we should be able to do that, but we need to do the things that you're describing. But it also seems that without a competent core and continually organic core of healthcare workers, can we even do that?
Yeah, workforce is a huge issue, not just in Arizona, but nationwide. We've done, and this is an exciting time though for advocacy, because if y'all have heard of the 988 hotline that's coming, where there'll be a 3-digit number. Well, that's prompting the whole country to go, oh, gee, that's got to connect to something. And so just the last night at like midnight, they released the new House appropriations bill that's got lots of money for mental health in it. And there's a couple of other bills percolating around, and that includes money for workforce development. Like, for example, just something that just affects my discipline in psychiatry is that you can get your loans repaid if you work in certain settings, and crisis wasn't included in that until just now recently, partially due to some advocacy that we did, because they wanted people working in long-term clinics, like medical homes that would take care of people forever. And so you could do all this work and like it wouldn't count for your loans to be repaid. So there was no one, that makes it harder to recruit people to do that. There needs to be funding for, they're opening up med schools all over the place, but we have a shortage of residency spots. So like that doesn't really do anything except create a bunch of unmatched graduated med students if you don't open up the residency spots to begin with. So there's a lot of advocacy work to be done around workforce and developing workforce. I think having an interdisciplinary workforce helps because you want people doing the things that like kind of focus on the things that only they can do with their training, and other people who can then do those things, so you're all working together. So you don't have one, you've got like psychiatrists working on certain parts, you've got our therapists doing certain things, case managers doing certain things, peers doing certain things, so that everyone's contributing as an interdisciplinary team, so which makes it more efficient as well.
Thank you very much. Back to you, Teresa.
Yeah. Detective Stamps, I wanted to get your opinion. I'm curious. Dr. Belfour talked about law enforcement and essentially being the first responders to a lot of the mental health issues that occur. And so in your opinion, what are some specific actions that law enforcement and healthcare providers can take to improve prevention and intervention in an effort to reduce incarceration of individuals with mental illness?
Yeah, and I know we've got someone from law enforcement here also who can probably speak to it more from their own experience. But for us, like, we participate heavily in the CIT training. CIT is a great program. It's the 40-hour training that for law enforcement to recognize mental illness. Usually there's peers and families involved in helping teach that. And so I think Arizona is pretty, many of the law enforcement agencies are doing that training. So that is a great first step, because then they're recognizing who doesn't need to be taken to jail. And then it's on us to make it easy for them. And having that, sorry, my cat is mouthy today. And just having that come from the top of leadership, Tucson Police, we're very fortunate with them in that they are very mental health aware, and they've got buy-in from their leadership on down. So they do invest the time and effort in the training, and they do participate in innovative programs like having crisis line staff embedded in the 911 call center so they can intercept calls so they never go through the police route if possible. So there's lots and lots of things.
Thank you, Dr. Belfour. Detective Stamps, I'd like to get your opinion on law enforcement involvement and coordination with healthcare providers for prevention and intervention strategies.
Well, just piggybacking on what Dr. Belfour said, I think we in law enforcement, I will say I did law enforcement for almost 24 years before I retired recently. And what I saw over that period of time was about 10 years of my career where we fought being the crisis workers and kept telling people we weren't crisis workers. And then about 15 years ago, we said, okay, nobody's listening, so we're just going to figure out how to be crisis workers. And that is kind of where CIT started, was kind of forcing our hand. And what is interesting is now we've kind of cycled back. We are getting to the point, because of liability, civil and criminal at this point, that we're looking at what we're responding to and what we're not responding to. Keep in mind when I speak, I'm speaking generically, but across Arizona, we have so many varieties of types of law enforcement. What works in Phoenix is not going to work in Navajo County. Everybody's kind of different. And we've addressed that in the training aspect. A lot of people talk about CIT and how wonderful it is. It absolutely is. That was my job, was putting that on. But we need to make sure that everybody, including leadership, understands that CIT is a very specific type of training. You know, it's voluntary, it's experienced officers. It's not everybody. Everybody always says that. I wish everybody had CIT. But that would ruin CIT. That takes the fidelity of CIT when you do that. My answer to that is always, how about we look at different training that applies to everybody? And that is what Arizona has done now. So in the last year, all of the academies were kind of forced, willingly forced, to include a lot more mental health in the academy. So we're getting that off and running. Everybody is using the same lesson plan. And they're teaching it in their areas. So I think that's super important to know that the training has improved. Everybody gets something. It's not CIT. But like I said, we want to keep CIT special. That's why we don't give it to everybody. But as from my perspective, as not a leader, not an official leader anyways, we really have to make sure that we're not just checking boxes. There is no one size fits all approach to this. The approach has to fit your community, your crisis system, and what that looks like. So when you go to leaders, they need to have functional answers for you. I saw a presentation recently when Phoenix PD talked about a co-responder model and how it did not work in Phoenix, because Phoenix is different. Phoenix is their own kind of agency, whereas in Mesa, we have a co-responder model that is very successful. And Tucson even had their own experience to that. So as easy as it would be, and Dr. Belfour pointed this out, to pick up all these wonderful programs, we really need to make sure that we're doing it effectively for your community and your agency. Because the reality of it is, as we keep going down the path that we're going between public expectation and civil litigation, law enforcement's going to start backing out a little bit. That intercept zeros really need to be addressed, because the intercept one is going to stop occurring sometimes. So we've really got to look at that zero and figure out how to do that. And I think in Arizona, we're finding wonderful answers to that. We're doing a lot of diversion, as Dr. Belfour said. Pima does it, Tucson does it, Mesa does it, Phoenix does it. Conversely, Queen Creek does it because we actually run our, Queen Creek runs our dispatch out of Mesa. And I think that's the way to go. It was kind of 988 before 988 was cool. And we're talking thousands of calls. So this isn't just a few calls here or there. Phoenix diverts, I think, over 500, maybe up to 700 calls a month. Mesa sometimes diverts 300 some calls a month. I can't speak for Tucson. I don't know what they do, but I know it's a lot. And that's the answer, because ultimately an intercept zero holds the other parts of the system accountable. Like all those years where it was law enforcement, and we speak about staffing when it comes to behavioral health. Well, I hate to break it to you, but cop staffing really sucks right now. We don't have a lot of officers. So throwing it back to law enforcement is really not going to be the answers. We just have to figure out how to do it on the behavioral health side, and holding people accountable. But what I have found is if you ask reasonably and you talk about what you want, then people are going to figure out a way to do it. You can't come at somebody from your own lens and say, this is what we want you to do. And I will say that from an officer, that's what we did a lot of times on behavioral health, on the call transfers, on the crisis teams. We were coming at them and saying, hey, we want you to do this. But the reality of it is we're not behavioral health professionals, and we should not be saying that. We should be saying, this is the result we want. How do you want to do it? And when we made that distinction, that's when these diversions started working, because they came to us and said, hey, we're comfortable doing a lot more than you think we are. We do this all the time. This is our bread and butter. So let us do it the way we want to do it instead of the way you think we should do it. And I think ultimately that is going to be the change in the system. And it's different. And I will speak as myself, as an officer. We're very type A and we like to control everything. So, when it's hard for us and for our leadership to let it go and just say, okay, this is yours now. What do you, we'll just let you do it, and not want to still be a part of that. So that is a very unique transition that we are coming to in law enforcement right now. We just kind of have to be flexible. You have to be flexible. You have to be willing to say, okay, that's not going to work here. It's a different area, or we tried that and it didn't work. Phoenix did it with the co-responder model, and that's okay. There's other things that we can do. It doesn't mean that they don't work. It just means it doesn't work there. And having that flexibility and willingness to have communication and open conversations, I think, is really how we have gotten to where we are in Arizona.
And to piggyback on that, it's an ongoing relationship cultivation. So we meet regularly with all the police agencies that we interact with. We go over data. We have a data on all the police drops, and if there's outliers that took a long time, why was that? If there's customer service complaints from either side, police say our staff was rude, our staff said the police was rude. That doesn't happen very much anymore, but in the beginning it would, and we would go over all of that stuff. And now we continue, most of the time we're not even going over problems anymore, because we've got such a tight relationship. Those things get solved in the moment. Now in our monthly meetings, we're looking at, well, what new thing can we do? What's a problem that hasn't been a burning problem, but now that the burning problems are mostly, being dealt with, like, what can we do to improve even more? We do the same thing with our emergency room colleagues too.
Thank you. I want to go to Mr. Jacobson now. I know a lot of the stakeholders talked today about how critical it is to have communication, stakeholder engagement, and to have coordination of care between agencies. As much of what happens at the intersection between justice and mental health begins and ends with the judicial system, how do you think we can begin to promote fundamental change?
Thank you, Teresa. Yeah, the discussion about that communication, about the interactions that we need, is so crucial and so fundamental to being able to make the kind of changes we want. And Justice Bruton, I was talking, talked about the civil commitment statutes in Arizona and how kind of busted they are. We need to fix those things. And that's only one example. You see, the issue is so many of our systems, and Amanda, you pointed this out when talking about law enforcement, but the same is true with the judiciary. Our systems were not designed to treat mental illness. This is not what the justice system is designed to do. For 200 years, we've been focused on dealing with a case-by-case approach to working to resolve that case. We take a case, we move it through the system, we try to do a resolution, we seek justice in that resolution, and then we seek whatever the consequences of that decision are, whether that's criminal, whether that's civil, whatever that is. We talk about those consequences. What's happened is, as a deinstitutionalization has taken place, we've seen more and more of these individuals come into the system. And almost everybody I talk to in the judiciary is frustrated because they see the same people again and again and again. They're just cranked through. They're through the revolving door. They're frequent flyers, whatever you want to call them. They're the same people. And what we're doing is not working, because obviously if it was, we wouldn't be seeing them again and again and again. So what our goal is, one of our big emphasis here, is to try and change that trajectory. These individuals need to create a new trajectory within the criminal justice system. And specifically, our focus is, of course, within the judiciary, but that doesn't happen alone. That happens in coordination and conjunction with all of our partners, everybody from law enforcement, jails, prisons, the REBAs, access, all the service providers, the hospitals, all the way down to the EMTs working with these folks on the streets. We're all part of how do we work and create these solutions. The thing is, we are trying to, within the judicial branch, is to train our folks to start to recognize that there's more to this than just resolving the case. We're moving, and this is a hard thing because, again, this was not our original design, but we're moving from this case-centered approach, looking at trying to go on a case, move it towards resolution, to developing a person-centered approach. How is this event, how is this instant, how is this process impacting this individual? And if that impact just cranking them through the system, then we need to change that impact. We need to change that trajectory. And that's a challenge because we're not designed to do that. And if you've had any experience with the judicial branch, you know that we are steeped in how we've done things before. Precedent is just everywhere. It's not how we've decided these things. It's not how we've done things. And we need to shift and change that. It's very difficult. And not only is it the individuals, it's also the laws and rules that control how we do our business that need to be changed. And then needs to open up a little bit so we can make some decisions that may not have been what we normally would have done in the past. But once we create those partnerships and those ties with other individuals, then we can have those opportunities to move those folks out of just the process we've always done into a process that truly will change them and change the impact of where they want to go. This is what we've been working on. One of our biggest emphasis, one of the biggest things we've been doing is trying to develop those relationships, those ties outside of just the judiciary. You know, Margie, you talked about the mental health system. It's complicated, it's difficult to get into, it's unknown. Hey, the same could be said a lot about the judicial system. People don't understand it, people don't know it. Unless you become part of it, it doesn't make much sense. Yeah, you could watch it on TV, but that's not what the reality really is. And so what we're trying to do is create those ties, those bonds. And we've done that through, we're supporting law enforcement, prosecutors, to develop deflection and diversion programs. We're working with our probation departments to make changes. And Access has been a great partner in this as well, in terms of they've actually set up clinics in some of our probation departments. We have 13 spread throughout the state. So when people come out of jail in the system, there's actually services there available to them to do these. And we're also then looking internal to create more education and knowledge and options. And that's one of the crucial things when we get Amelia, you can jump in and support this, I hope, in that when a judge sees an individual and knows that there's something wrong here, this system is just not going to treat this person right and correct if we take a traditional approach to dealing with this case. We need to have options to be able to say, we need to treat this in a different way. And mental health courts are a big part of that, but there's more than that. We need to treat that individual, not just through the mental health courts, but in all case types. And Justice Bruno mentioned juvenile, mentioned family court, civil, all these different types need to be working together. So breaking down those silos, both internally and externally, becomes one of our biggest challenges, so that we can communicate both across our case types as well as to those who are in the community and providing the services that we need to have access to.
Thank you, Mr. Jacobson. Did anyone have anything they wanted to add on that? Oh, sorry, go ahead.
No, I was just going to concur with Mr. Jacobson, is that it's very true. I mean, one of the things is that it's a mindset, it's a certain way that the courts run in terms of rules and statutes that we have to follow. And sometimes it gets very challenging when we have these individuals come into our courts and, we're dealing with a different type of population. And we're also trying to make sure that, we're working with them in trying to get the resolution in the courts, but we're also wanting to make sure that they're getting the help that is appropriate. So the challenges can be all around. And I think, like Ms. Belfour had mentioned before, when we're talking about, some of the services, like, for the homelessness, for the homeless individuals, there's just a lot of, there's just not so many services that we can go ahead and count on in our community. At least I can say that, because I know in bigger communities you have those resources. We don't have those resources here, which becomes pretty challenging. But I think in developing these specialty courts, I think it gives more attention to the individual to be able to not only get them through the legal system, but also that's why, I call my court the empowerment court. Behavioral empowerment court, because one of the things that we want to do is we want to empower these people to be able to go back to the mainstream and be able to function just like all of us do. Sometimes it's really difficult, but one of the things we have to do for them is make sure that they have the support system, because if we just go ahead and take them through the legal system and then put them back out, we're really not getting anything achieved for these individuals. So there's a lot of work still to be done, but I think this is a way to start. and start getting everybody to hear what we're doing to make sure that everybody can face the same vision and eventually be able to work together in making this more fluent.
Absolutely. And there's a question in the chat about, Jill and Kelsey, about people losing their medications when they go into jail. Not necessarily. But what happens is if somebody is arrested, according to federal regulations, Access can no longer provide benefits to that individual. So the benefits are suspended. Now, it used to be they actually dropped the benefits altogether and they had to reapply and go through the whole thing. We've been able to set something up with Access, so they're only suspended and then they're begun again once that individual is released from jail. The bigger problem is that the jail formularies aren't necessarily the same as what they might have had before. So there might be huge shifts based upon coming into jail, coming out of jail, those kind of things. And that is actually right now one of the bigger problems, because there are medications provided into jail for those who have serious mental illness, but there may be changes and differences because some of the medications are very expensive and jails work on a budget. So they have a limited formulary that they have to work within. So it's a great example. The reason I wanted to touch on this is a great example of communication. We've made some progress on that by working with Access and only suspending rather than ending services when an individual is arrested. But there's still a long way to go to find ways to support those individuals, whether they're in jail, out of jail, and a transitional portion of that as they come in and out.
And that's another advocacy point. There's people working on advocating for changing that, because and even bringing court cases as well as legislative changes, because if you think about it, you've turned their benefits off and they haven't even had a trial yet. So like that could be unconstitutional. I think it is, but I'm not in charge.
Yeah, even the question of incarceration, Margie, you bring up. I mean, incarceration is an individual who is pretrial incarcerated, has not been convicted of anything yet.
Yeah.
And often they're held, sometimes because there's a lack of understanding of what the issues they're truly dealing with are. And they're seen as a danger to the community when that may not be the case. There's just a lack of understanding of what their needs are and how to restore them to a level of competency to either stand trial or be returned in the community, and how that can be done. And just be honest, everybody knows incarceration is not the best therapeutic environment in which to restore these individuals. It's just not. Putting somebody in a cell does not help them. So we need to find ways to do this in outpatient and out of custody mode that creates those benefits so that they can truly not only deal with the case that's before them, but also become back into the community and start to have some balance in their lives.
So, hi, real quick, do you guys mind if I chime in about something really quick? Is everybody okay with that? Yeah. So my name's Holly, and I'm the RSS Southern Region Coordinator for Arizona Department of Correction, Rehabilitation, and Reentry, the big old long name. Just two quick things. I certify RSSs through the state of Arizona while they're incarcerated. So now they work for us as RSSs, and we've peggied with Richard from Hope, and he does in-reach with us. But our RSSs are trained in crisis. They help the correctional officers, the sergeants, the deputy wardens, the assistant deputy wardens, when they have somebody with an SMI, or if it's just somebody that found out their mother passed away, and we know they could potentially be in a crisis. So the RSSs are being called up to help with things like that. We've taken some RSSs and renamed them to RPSs, which is a reentry preparation specialist. So they work with that CO3 that, say, at Santa Rita, I'm on yard 3. So CO3 Castro's on that yard. She has an RPS that works with her Monday through Friday, 8 to 5 while she's there. And that person is meeting with all her caseload that's getting 30 days to the gate and saying, okay, here's your access application. I'm gonna help you fill it out. Here's your driver's license application. Here's a social security card. Here's all these applications. You're gonna sit here with me and fill them out. And if you need help, I'll help you. They get it all faxed in. So, and Richard can vouch, when these guys get out, the next day they're calling and their access is already reinstated. So they're going back to behavioral health. They're going back to getting meds. They're engaging in services that they normally wouldn't have done being incarcerated, and they're just opening up the gate and going, okay, bye, see you later. You know,
Holly,
we're
that's a
trying
great
to
place.
piggyback that with Hope and with other agencies, of course, in Tucson, but Hope has been our biggest asset right now in helping us do this type of work in the community with the guys and girls incarcerated, because we're not just doing it here in Tucson, we're doing it through the whole state of Arizona. So
Thank you, Holly.
I have quite a few RSS working for me.
Well, thank you. That's a great place to have us end up today. I'm sorry to cut you off, but we have a limited time, and David's Hope would like to leave us with some final thoughts. But before we turn this over to David's Hope, Teresa and I have one more thing we're going to ask you, and I put it in the chat. If you all would share with us one takeaway from today or your call to action, we'll organize these, we'll provide them out to you, and we'll provide them to David's Hope. And thank you all for a really, really exciting conversation. We could have gone on for 2 to 3 hours, I know. There's so much action in the chat. There's so many resources being shared. So thank you all very much. Teresa, I'll turn it over to you, and we'll be done for today.
Thank you. I just wanted to thank all of our panelists for taking time out of their day to have a very lively and passionate discussion. I am very impressed with all of you, and I want to thank you again. And then I'll hand it over to Kelsey to close out.
Hey guys, I just wanted to thank everyone on behalf of David's Hope and the Coalition. That was incredible. I want to thank the Mayo School, the Mayo Clinic School of Medicine, and their incredible students, Kelsey, Chris, and Scott. You guys ran this whole show. We're glad you made us a part of it. Thanks to the moderators and the panelists. And I just want to, I know I speak on behalf of the entire coalition when I say we want to thank Mary Lou Burnsick, who is the director of David's Hope, who has been our fearless leader for years and years, and basically single-handedly got all 15 counties to sign on to the Stepping Up initiative. Without Mary Lou, we never would be where we are today. So just sending all of my gratitude to everybody, and especially to her. I am going to stop the recording, and I'm going to wrap it up and honor everybody's rest of the afternoon. So thank you, everybody, for participating.
Thank you.
Thank you all so much.